Hey, people of the Invictus Free Podcast. Want to do some updates. We've laid down a lot more video, a lot more questions, a lot more summaries. It's happening soon. And actually, ahead of the release of the full Invictus, we're doing Encore, which is for the oral exam. So that's going to come out in the not too distant future, much shorter, but it's all about preparation for that new oral exam, which is very different from the old oral exam. But today, what I want to talk about is some dermatology because I hate dermatology. We've been talking about some rashes on the show. Let's talk about another thing. Let me give you a case. It's a 20-year-old female. She comes in and she's had fever for a few days, some aches and pains. She's got some mucosal lesion and just sort of this diffuse rash that developed this morning, and which was the thing that made her come in. When you look at her, you see that she doesn't look too well. She looks a little bit toxic, and sure enough, she's got some lesions in her mouth, in her mucosa. She's got some redness of her eyes. She's got this sort of diffuse rash. And what do you think this could be? It's very non-specific, right? And that's the point. It's very non-specific, but one of the things that's really concerning, obviously, is the fact that it is involving the mucosa. And anytime you've got a diffuse rash that involves the mucosa, you've got to think about Stevens-Johnson syndrome. And when you think about Stevens-Johnson syndrome, you think about drugs, and you think classically the thing is sulfa drugs, but a whole bunch anti-epileptics can do it, non-steroidals can do it. There's a bunch of drugs that can do it. And there's also infections like mycoplasma, viruses. So there's a bunch of things that can trigger this, which then probably turns it into an autoimmune disease where you start getting cleaving of the skin. And so one of the classic things with Stevens-Johnson syndrome and toxic epidermal necrolysis, which is really just the severest form of the disease, is that you can have a positive Nikolsky sign. So you over time might develop bullae, and those bullae, as you press on them, they can sort of cleave that epidermis and get bigger and bigger and bigger, as you can see in some of these pictures. It can start off as these sort of targetoid-like lesions, then bullae, and then, as if it's a really bad form, you can slough all this off. And it looks like and acts like and should be treated much like a burn. It can also affect the eyes. It can affect the mucosa all over the body. And even today, it has a significant mortality in the severe form. So classically, toxic epidermal necrolysis is when more than 30% of the skin is involved. And Stevens-Johnson's when 10% or less of the skin involved, and then there's that place in between, the 10 to 20 to 30%, where it's sort of an overlap between the two. The diagnosis is classically made just sort of on the history, the physical. Yes, you can do skin biopsies and kind of work out with the histology what it might be. The differential diagnosis is pretty broad, but if there's no involvement of the mucosa, it is unlikely to be Stevens-Johnson syndrome or toxic epidermal necrolysis, and that might come up and probably will come up in the question. So you can have a number of different patients that present like this, but if there is not mucosal involvement, it's not likely to be Stevens-Johnson's or TEN, and if there is involvement of the mucosa, then it is much more likely to be that. What is the treatment? The treatment is supportive, fluids, nutrition. Steroids are very controversial. There's a timing thing here. Maybe if you get them early, it can reduce the disease. And maybe if you give it later, it can make it worse. So very controversial. You do that in association with a dermatologist. What else can we give for these people? We can certainly give IVIG. That appears to help. Then there's stuff like plasmapheresis and some of these tumor necrosis factor blockers, which may be helpful, but overall, mostly in the emergency department, it's supportive. And also the eye involvement can be quite severe. So you're going to put in artificial tears. And if there's big time sloughing of the skin, you might want to be trimming that up and putting on non-adherent dressings. And if there appears to be secondary evidence of infection, you might give antimicrobials, but you don't do that up front. That can sort of complicate the picture. And again, think about this as like a severe burn. That's how you would treat these people. So there it is, Stevens-Johnson syndrome, toxic epidermal necrolysis, caused by a lot of drugs. Some infectious disease can do it as well. Mucosal involvement is the key thing. Targetoid lesions initially, positive Nikolsky sign. All right? So I'll do some more of these, and this is all as we ramp up to do the big giant dump of what is going to be Encore, which is for the oral exams, and then Invictus, which is our big board review course. So you're going to get a huge dump of content. But then, unlike anybody else, we're going to continue to do live events and question banks and add to this and have the discussion and make it a community so that you can crush your exams, but also in-service exams and final exams. But also you might want to continue to be a part of this community for your entire career, because I've always believed that good emergency care requires that you do continuous board review, that you learn this stuff over and over and over again, because anything can come through that door. All right? Herbert out.